A very good morning to everyone, respected professors, senior consultants, colleagues, and dear friends. It's a pleasure to welcome you all to the CCP Specialty Update in Internal Medicine, organized under the auspices of the Ceylon College of Physicians. Today's program brings together updates, case-based discussions, and shared clinical experiences that reflect the realities of day-to-day internal medicine practice. To formally begin today's program, I kindly invite Professor Namal Vijay Singha, a distinguished cardiologist and academic, President of the Ceylon College of Physicians 2026, serving as a Professor of Medicine at General Sir John Kotalawala Defence University of Sri Lanka, to deliver the welcome address.
Good afternoon, everyone. Dr. Madhuwanti Hettiarachchi, President of the Sri Lanka College of Internal Medicine, and my colleagues, ladies and gentlemen. First of all, I welcome you to this specialty update. This is another educational program we do regularly from the college over the years. And for 2026, this is the first specialty update. We have planned to do 8 such specialty updates with the collaboration of our sister colleges. And this is the first one because we thought of starting with internal medicine with collaboration of Sri Lanka College of Internal Medicine, because that is one of the main colleges and the main components of the College of Physicians. And I hope you will get the maximum benefit out of it. And I must thank Dr. Suranga Malilgama. He's the person who organized the specialty updates on behalf of Ceylon College of Physicians. He's one of our prominent persons as well as a fellow of the college. So I thank all the resource persons. They are, I can see that they are past presidents and prominent members of the Sri Lanka College of Internal Medicine, but they are also members of and the fellows of College of Physicians as well, like me. And I hope you will get maximum benefit from the experience that they are going to share with you. And also I thank the senior registrars who volunteered to come here and do your presentations. Thank you.
Thank you, sir. Following that, it is my pleasure to invite Dr. N. Madhuwanti Hettiarachchi, President of the Sri Lanka College of Internal Medicine for 2026, consultant physician in internal medicine with a special interest in toxicology, currently serving at the Teaching Hospital of Peradeniya, Sri Lanka, to address the gathering.
Professor Namal Vijay Singha, the President, Ceylon College of Physicians, and all the other consultant physicians, and everyone who is gathered here for the specialty update, combined effort by Ceylon College of Physicians and Sri Lanka College of Internal Medicine. And I thank the CCP especially for arranging this collaboration with us and for inviting us to be the first in this kind of lecture series. And as you are aware, internal medicine is the complex where we engage in managing complex patients. And I think that today array of lectures is such that it explains what we learn as internal medicine. So I invite you all to gather information, and especially I thank the expert panel who is sharing their expertise today. Thank you.
Hypertension remains one of the most common and impactful conditions we manage in clinical practice with evolving evidence and guidelines. So, let's start off with today's first scientific session. I would like to invite Dr. Kumudini Jayasinghe. Dr. Kumudini Jayasinghe is a consultant physician specialist in internal medicine currently attached to the National Hospital, Kandy. She is an author and content reviewer of the 2022 Hypertension Guidelines for Secondary, Tertiary, and Primary Care in Sri Lanka. She currently trains postgraduate trainees in internal medicine, dermatology, hematology, chemical pathology, emergency medicine, and sports medicine. Dear Madam, I cordially invite you on stage to speak us on an update on hypertension.
Thank you very much for those kind words of introduction. At the outset, I would like to thank the two colleges, Ceylon College of Physicians and Sri Lanka College of Internal Medicine, for inviting me. So this is about the update on hypertension. Before I talk about the updates, I would just give a brief introduction about what is hypertension. And this is the most prevalent and the modifiable cardiovascular risk factor. And there are about 1.4 billion patients are having hypertension. Out of that, 2/3 are in the low and middle income countries. And there are about 10.8 million avoidable deaths every year. So in Sri Lanka, according to this 2021 STEP survey, that there are 1 in 3 adults are having hypertension. About like prevalence is 34.8%. So it's actually 25% rise when compared to the 2015 survey. So what is important here? 5 millimeter of mercury decrease in systolic blood pressure result in the reduction of mortality in stroke in 14% and in heart disease 9% and overall mortality by 7%. So keep that in mind so that you will understand why that is important. So in this talk, I will mainly discuss about the 2 recent guidelines, that is ACC/AHA 2025 and the ESC 2024, but mainly on the ACC/AHA 2025, and with some box recommendations. Remember that I will not share all the updates. It's impossible. So I will advise you to read the full guideline and also the box recommendations. So these are the 2 guidelines. So when you manage a patient with hypertension, it's very important to know some key numbers. First one is the blood pressure categories for the diagnosis, and then when to start the antihypertensive and what will be your blood pressure goal or target. So first we come to the diagnosis. There are 2 methods mainly, out-of-office measurements and the office blood pressure measurements. So out of office, there are again 2 home blood pressure monitoring and the ambulatory blood pressure monitoring. So what does the guideline say? So the ACC/AHA, they recommend only the out of office blood pressure monitoring, either home blood pressure monitoring or ambulatory blood pressure monitoring. They strongly recommend this. In the ESC 2024, they again recommend out-of-office blood pressure monitoring, but at the same time, they have said if it is not logically or economically feasible to arrange the office blood pressure monitoring with repeat measurements and with the automated, validated blood pressure apparatus with correct technique. And remember that in patients with atrial fibrillation and also pregnancy, that you need to use manual auscultatory method. So what are the blood pressure categories? In the ACC/AHA that you can see, what is normal blood pressure? It's the systolic blood pressure less than 120 and the diastolic less than 80. And they call it hypertension when it is above 130/80. So in between that, they have a category called elevated blood pressure. That is in between, like 120 to 129 systole, and diastole is less than 80 again. So blood pressure in hypertension, there are two categories, stage 1 hypertension and the stage 2 hypertension. What is stage 1 hypertension? It's the systolic blood pressure 130 to 139 and the diastole 80 to 89. And the stage 2 hypertension is when the blood pressures are above 140/90. What about the ESC? ESC, they don't have normal, but they have called it, instead of that, they have called it a non-elevated blood pressure. That's less than 120/70. So they have the lower diastolic blood pressure compared to the ACC. And the hypertension, they call it, when it is equal or more, 140/90. So in between, again, they have said it's an elevated blood pressure. So compared to the 2018 classification, there are many. So now it's easy. There are no difference. They have both the in-between category called elevated blood pressure. So when you compare the two guidelines, you can see that office blood pressures and the out-of-office blood pressure and the ambulatory daytime mean is all same in the 2025 ACC/AHA. So it's very easy for you all to remember. Whereas in the 2024 ESA guideline, they have said it's a blood pressure we have already discussed, it's equal or more, 140/90. But out of office and the daytime mean is a 5 millimeter lower than the office blood pressure. I hope everything is clear. So let's discuss a case now. A patient with a newly confirmed diagnosis of hypertension should have the following initial tests. Test. Echocardiogram, urine albumin creatinine ratio, or urine protein creatinine ratio, same. 24-hour urine protein, or ultrasound abdomen. What do you all think? I'm sure that you all know the answer. So it's a urine albumin creatinine ratio. This new guideline is a new addition in the 2025 ACC/AHA. So in 2017, it was optional. Now it's a mandatory. It's recommended in all the hypertensives. So why it is important? Because high urine albumin creatinine ratio is a detection of early kidney damage and early risk stratification. Again, that's a new risk stratification. That is, which is called Prevent CVD Risk Calculator. It provides both 10-year and the 30-year severe risk. And that you check this cardiovascular risk with the risk calculator with the patients who are not having any high cardiovascular diseases. I'm sure that everyone knows it. So this new risk calculator has components of cardio-renal metabolic. Because other than the lipids and blood pressures and the smoking and thing, they have the optional components of urine albumin creatinine ratio and the HbA1c also. So it more accurate is across diverse population. I'm sure we also should be able to use the same. And it does not include race as a variable. ESC score 2 is the same one. It's not new. So when to start antihypertensive medications? According to the ACC/AHA, in the stage 1, I'm sure that you can remember the blood pressure values. Just check whether the patients are having the high cardiovascular risks, like already established cardiovascular diseases, chronic kidney disease, diabetes, and all. If check with the prevent risk calculator, if it is more than 7.5, then you need to start antihypertensives along with lifestyle therapy. This patient is having the high cardiovascular risk. Need to start treatment in the stage 1. if it is without any, like a high cardiovascular risk, without those diseases, and also prevent risk, risk is less than 7.5, then patient would be given the lifestyle changes for 3 to 6 months. And then after 6 months, that we can review with the patient. If the blood pressure remains the same, that you need to start antihypertensives. So if it is stage 2, when the blood pressure is more than 140/90, start the antihypertensives along with the lifestyle changes. So usually 2 drugs are essential and encouraged, and if available, that combination pill. ESC, when it is like a hypertension more than 140/90, to start antihypertensive treatment. What about the elevated blood pressures when it's 130/39, 139, and 80/89? So consider starting antihypertensives when the patients are having high cardiovascular risk, such as established cardiovascular diseases, CKD, diabetes, familial hypercholesterolemia, and the target organ damage, the score more than 10%. But they don't, after the kind of lifestyle changes, if they are not having any of these things, then they don't discuss about the starting antihypertensives in the ESC. So there are 3 main classes. So no change, but remember there's a little change in the ACC/AHA. There's no thiazide diuretics for their guideline. It's only thiazide-like diuretic. So indapamide, chlorthalidone. Chlorthalidone is now available in Sri Lanka. That's a very good drug, actually, long-acting. Its efficacy sometimes goes beyond 24 hours. And the hydrochlorothiazide is a known drug, thiazide diuretic that we have. The ACE inhibitor or ARBs and the calcium channel blockers. Remember these, as much as possible, use long-acting antihypertensives, and because you can use once daily to improve compliance. Sometimes what I have seen, that even amlodipine you used to give is twice daily. Remember, it's a once daily medication. Don't divide it into give twice daily. And start if you want to start the 5 milligram, start once daily. Same as with the enalapril also. And the other diuretics, same. So a stage 1, ACC/AHA says start with the monotherapy, and the stage 2, the combination therapy. And especially in the patients are having elderly and also diabetics, you need to check for the orthostatic hypertension. And in the elderly, you have to start low doses, and you need to up titrate very slow. Low, and the go, you need to go slow. Remember that. What is our goal? ACC/AHA, what's their blood pressure target? Systolic blood pressure, they say it's less than 130, but preferably less than 120. But they don't give a lower limit. And the diastolic blood pressure less than 80. So there are, since 2017, there are so many trials, such as STEP and the ESPIRIT. They have shown that the benefits by lowering person's blood pressure, including reducing the number of adverse heart events and the death. The reason is this, by going for the lower values with the new guidelines. What about follow-up? What is new? The ACC/AHA says to follow up with the home blood pressure monitoring, and strongly emphasized and also encourage the routine monitoring for the treatment adjustment and also ongoing management in most of the patients. And it's with again with a multidisciplinary team, not only with the physician. So let's move to the case 2 now. The patient is taking enalapril 5 milligram once daily. Home blood pressure average for last 3 months is 116/72 millimeter of mercury, and the office blood pressure average 3 readings around 136 and 86. So what is the next appropriate step? Increase medication dosage, add second antihypertensive, continue present medication, and look for high blood pressure at clinic, reasons for high blood pressure at clinic level. All are silent, yeah? Okay, so continue present medication. Why? Because we are going with the home blood pressure monitoring. Home blood pressure monitoring is normal. So you can, even in the clinic levels, it's high, that you can still rely on the home blood pressure monitoring. So now we'll move to the lifestyle and psychosocial approaches, very important component. The weight loss for those with overweight and obesity, and heart health diet or DASH diet, salt restriction, and the modest dietary sodium intake, about 3,500 to 5,000 milligram per day, and the aerobic and resistant exercises, aerobic exercises at least 5 days per week, 150 minutes, and the resistant exercises at least 2 days per week. And the stress management practices, they have again given it as a two-way recommendation, and like with the yoga and mindful meditations, it also reduces the blood pressure. And what about this increased potassium? This is a new addition for the ACC-AHA. They suggest potassium-based salt substitutes, that these substitutes will have the 25 to 30% potassium chloride and the 65 to 75% sodium chloride. And that is kind of the two-way recommendation, but level of evidence is level A. And so other than that, there's already the dietary, the intake of adequate potassium supplementation, ideally from dietary sources, is a second box, is recommended. Actually, it was there in the previous 2017 guideline also. So potassium intake is very important to reduce the blood pressure. Role of potassium, actually, it's a ratio of sodium to potassium is the most important factor in hypertension. That its regulation of vascular and sensitivity catecholamines and also inhibit the plasma renin activity and the promotion of natriuresis also, thereby reducing the blood pressure. The salt intake, there's again new addition. They recommend is very low levels now, that 2,300 milligram per day salt intake. Ideal target is less than 1,500 milligram day. I'm sure that meals will be not palatable at all. And but this recommendation is that. But remember that in patients who are having the salt restriction may be contraindicated in patients with severe symptomatic orthostatic hypertension, and also the patients who are having hyponatremia are the patients that you can definitely you need to reduce the salt intakes. So there are some randomized trials actually which shows the first two trials shows the reduction of sodium in showing the evidences. These are like one trial tone that was somewhat not a recent trial, but again it shows the 21% reduction in cardiovascular events, and also the trials of hypertension prevention. This trial again shows the 30% reduction with CV events with the reduction of dietary sodium. What is important here is the increase like a potassium salt, substitute with the potassium salt, that it shows the 41% reduction of cardiovascular event. So you can see when you take like a potassium has given more beneficial effects in reduction of cardiovascular events and the blood pressure as well. So this is about our data. We can see our intake of sodium is very high, about 8 to 10 grams per day. This is a very recent one, and a cross-sectional study. And we have other components also, high BMI, the job stress, and also the low physical activity in 75%. So, but we have no the cardiovascular events or other data available, and also potassium intake as well. So what about the alcohol intake in hypertension 2025 update? That they suggest to again the reduce, minimize alcohol intake or avoid if possible. If anyone is drinking, it's men less than 2 drinks per day, and women is less than 1. So we know that alcohol definitely increases the risk of atrial fibrillation, stroke, heart disease, and cancer as well. So diabetes, again, there's a new addition, and other than that, starting antihypertensives in more than 130 systole. And when the patients are having the CKD, microalbuminuria, and to start the ACE inhibitors, ARB, in that situation, otherwise it's all the other antihypertensives could be used in diabetics as well. What about in pregnancy? That there's a little update, and that when the need to start antihypertensives when the blood pressures are more than 140 or equal 90, more than or equal 140/90 to reduce adverse outcomes, and also to keep it less than 140/90. But remember, diastolic blood pressure should not reduce less than 80. And when the blood pressures are more or equal 160, 110, so it's very important to reduce the blood pressure within 30 to 60 minutes to low levels. And with the patients with chronic hypertension, if they want to get pregnant, and to start low dose aspirin to prevent them getting preeclampsia. That is a primary prevention. Dementia. Intensive blood pressure control will reduce risk of developing dementia by 12 to 19%. So it's a class 1 recommendation to reduce the blood pressure to less than 130 systolic blood pressure to reduce the cognitive impairment and the dementia. There are evidence with the randomized trials. So resistant hypertension, I will share only one slide. That is you need to screen for primary aldosteronism. Why? Because 25% of people with hypertension have PA, and only a minority with hypertension are screened for PA. So new recommendations with the 2025 ACCHA, all the resistant hypertension, irrespective of hypokalemia. Why? Only 25% of PA will have hypokalemia. And the young and also patients with obstructive sleep apnea, there's an association with each other. Severe hypertension, so when it is more than, you don't call it hypertensive urgency anymore, it's a severe hypertension. So when it is more than 180, 110, exclude the acute end organ damage. If that is the case, that you need to start IV antihypertensives. Otherwise, you don't need to need to admit these patients unless there's a acute end organ damage. But you can suggest the patient to monitor blood pressure and review them early and start medications early. But if the patient is already chronic end organ damage, like if you do the ECG, if there's a left ventricular hypertrophy, you can start treatment immediately. And remember, when a patient is admitted for some other illness, patient is having hypertension, but now it is very high, you don't start any IV antihypertensives or additional antihypertensives. So that is class 3 is one that can cause more harm. Remember that. Most of the I know doctors, they are panic when they see these very high blood pressures in the ward. They keep on adding medications. So the patients have so much of stresses when they are admitted. So you need to reduce the stresses and then start antihypertensives. So continue their usual antihypertensives. So you can see the recommendation is class 3, not to start. So this is going beyond guidelines, but I thought of sharing this slide. There are two, the upcoming antihypertensive. One is Baxdrostat, that is aldosterone synthase inhibitor, that causes 10 millimeters systolic blood pressure reduction. That it might replace your MRA. So it's currently undergoing phase 3 trials. Very soon, that in 1 to 2 years, we should get these results. So the other one is Silibesiran. It's a siRNA targeting angiotensinogen. So it's a kind of an injection. So once you give this injection, the efficacy will be there for 1 month. So it's currently in the phase 2. Now early phase of completed phase 2 and the early phase of phase 3. So we'll see. So to summarize, what are the takeaways? So confirm the diagnosis properly, very important. Use home or ambulatory blood pressure monitoring and assess kidney damage early. So request urine albumin creatinine ratio in all the patients. I'm sure that we know it for diabetes, we do it for diabetes, so why not it for hypertensives? Treat the risk-based, assess the risk and the patient's overall cardiovascular risk and start treatment accordingly. And the prescribed lifestyle changes along with the medications, so reduce sodium, increase potassium intake, limit alcohol, and address stress. So manage hypertension in pregnancy proactively, start treatment earlier, aim for clear blood pressure targets, and use low-dose aspirin to prevent preeclampsia. Initiate therapy to lower blood pressure in addition to lifestyle treatment is recommended for all patients with when the average blood pressure is equal or more 140/90, and if the average blood pressure equal or more 130/80 with high cardiovascular diseases or prevent risk more than 7.5, and the average blood pressure equal or more 130/80 without cardiovascular diseases and the risk less than 7.5 after 3 to 6 months of lifestyle changes. And your blood pressure goal should be less than 130/80, preferably less than 120, and the diastolic blood pressure less than 80. And the elderly people, what they have said is you need to individualize. Sometimes some patients can tolerate the low blood pressures, some will not. So anyway, it's very important to start with the low doses and up titrate to get the targets, but it's always individualized especially in elderly people. Remember that as well. But you can't give a kind of a same targets for each and every patient. So the reduced risk of dementia by reducing systolic blood pressure less than 130/80. And my last slide, the lowering in blood pressure reduces cardiovascular risk, and the current guidelines recommend going lower when safe and well tolerated. Thank you.
Thank you, Madam. Please remain on stage. I would like to invite Professor Namal Vijayasinghe and Dr. Madhuwanti Hettiarachchi to present the token of appreciation to Dr. Kumudini Jayasinghe. We now move on to a very practical and engaging part of today's program, case-based discussions, where learning is grounded in real clinical experience. The first case is a thought-provoking presentation on osmotic demyelination related to diabetes insipidus. The case will be presented by Dr. K. Nilusha Madurangi. Dr. K. Nilusha Madurangi is a senior registrar in general medicine, currently attached to National Hospital of Sri Lanka. She completed her MBBS degree at the Faculty of Medicine, University of Sri Jayawardenepura in 2018 and received her MD in Medicine from the Postgraduate Institute of Medicine, University of Colombo in 2025. Madam, I invite you on stage. The case discussions based on this topic will be led by Dr. Harendra Karunatilaka and Dr. Nandana Dikmadugoda. Dr. Harendra Karunatilaka is a consultant physician and a specialist in internal medicine currently attached to the National Hospital of Colombo. He completed his MBBS degree at the Faculty of Medicine, University of Colombo, and received his MD from the Postgraduate Institute of Medicine, University of Colombo. Dr. Nandan Dikmadugoda is a consultant physician in internal medicine currently attached to the National Hospital of Sri Lanka. He completed his MBBS degree at the Faculty of Medicine, University of Ruhuna in 1995 and received his MD in 2005 from the Postgraduate Institute of Medicine, University of Colombo. Dear Madam and Sirs, the stage is yours to proceed with the discussions.
So, good afternoon, everyone, and I thank the opportunity given, and thanks for the kind introduction. So today we are going to present an unusual case of osmotic demyelination related to diabetes insipidus that we managed in our ward 56B. So our story begins with Mrs. X from Muddaragama. She's 63 years old and diabetic for 3 years duration on oral hypoglycemics with poor glycemic control. However, on admission, she had no micro or macrovascular complications. She has presented to the local hospital on November 26th with fever for 1 week duration and lower urinary tract symptoms. There, she was treated for urosepsis and ultrasound evidence of AKI with IV antibiotics for a total of 7 days duration. However, on December 3rd, she has developed altered level of consciousness, and there she has requested a self-discharge. They have given on discharge 3 vials of IV sodium bicarbonate just before the transfer, probably assuming uremic encephalopathy. However, I would like to highlight here that the sodium was 122 on discharge. So on admission to National Hospital Sri Lanka, she had fever for 2 weeks duration and altered level of consciousness for 1 day. Her GCS was 13. She had eye-opening to verbal commands and confused speech with obeying commands, and the tone, power, reflexes, plantar were normal. The first ABG that we did on admission had serum osmolality of 361 with a hypernatremia, with the sodium risen from 122 on discharge on the same day to 172 at NHS, National Hospital Sri Lanka. So this was, we have excluded HHS and DK with a CBS of 473 and urine ketone bodies negative. We managed initially with for hypovolemic hypernatremia, corrected the volume deficit with normal saline. However, switched to half normal saline and 5% dextrose with a background history of acute correction. So on the blood gas, there was acute respiratory acidosis with possibly the uremic and the metabolic encephalopathy and hypoventilation. However, the bicarbonate was more than the compensation, which was indirect evidence of actually that she had been given 150 millimole of sodium bicarbonate at the local hospital. So this was how she had, during the ward stay, her GCS fluctuated, and on day 8, we noticed a left side weakness which proceeded to involve all 4 limbs, that is quadriparesis by day 10. So there, with the background history of hyponatremia being acutely corrected, we suspected osmotic demyelination and proceeded with the MRI brain. Then, despite correction, she persistently had hypernatremia, so we proceeded with osmolality studies as well. So on day 3, you can see here, her serum, her serum osmolality was 370 with urine osmolality 266 and urine sodium excretion was 63. However, by day 14, her urine serum osmolality was 327 with urine osmolality rather dilute and with the serum osmolar gap normal. So it was the serum osmolality was because of hypernatremia itself, but the urine was not concentrating enough. So we suspected diabetes insipidus here and proceeded with a desmopressin challenge test. Before the desmopressin being given, the urine osmolality was 125, and after desmopressin, there was a complete response of urine osmolality turning to 305. So this was tallying with the complete cranial diabetes insipidus. And why initially she had normal osmolality studies. So the secondly only we saw the development of cranial DI. So why was that? So there we looked for evidence of osmotic demyelination and we found that hypothalamus is involved in addition to the midbrain basal ganglia and thalamus, and especially the pons was normal, so this was extrapontine osmotic demyelination syndrome. And with the involvement of the hypothalamus, so we looked to see whether other functions of hypothalamus involved or not. So her water, the thirst, circadian rhythm, emotions, and memory were difficult to be elicited because of a low GCS and NG feeding. However, we noticed that there was autonomic instability with variations in blood pressure and heart rate. And she also compatible with autonomic instability, and despite she had intermittent fever that was difficult to interpret with the hospital acquired infections, there was cranial diabetes insipidus, and the anterior pituitary hormones, the cortisol response was appropriate for her stress level. TSH was normal for a low T4, however that was difficult to interpret with the non-thyroidal illness. LH, FSH and growth hormone were not available for us to proceed. So down the line, we initially with the low GCS did a L lumbar puncture to see whether meningitis was a possibility, and what was interesting was protein was 113 with the normal sugars and lymphocytes too. Culture was negative, gene expert was negative. We couldn't proceed with MRI spine and CECD cap to exclude any possibilities of paraneoplastic and other demyelinating diseases. So whether this was related to osmotic demyelination syndrome itself was still a dilemma. But however, we could find some case studies where routine even though routine CSF studies are normal, high protein concentrations due to myelin basic proteins levels in some cases in both pontine and extrapontine myelolysis. So in treating this patient, there are several modalities of immune modulating therapies, IVIG, steroids, and plasmapheresis, and there are multiple case reports supporting with successful outcomes in all three modalities. And here I have highlighted two such ones done by Dr. Bimsara Senanak and the team supporting plasmapheresis, and Professor Indra Kumar and the team supporting steroids. So we proceeded with the plasma exchange, and on day 24, by day 28, she had GCS improve. We noticed the GCS improvement, and power, reflexes, and plantar also were improving. Plantar was downgoing. Initially, it was upgoing. So, however, she later on managed to sit up on bed with support on chair as well, and GCS improved to 14. but later on, she succumbed to sepsis and finally passed away with hospital-acquired infections. So the dilemma in our case was that what we observed was a secondary cranial diabetes insipidus following osmotic demyelination with involvement of hypothalamus, possibly due to hyponatremia being corrected with sodium bicarbonate. However, we could not find any evidence in the literature supporting this chronology. On the contrary, there were so many other case reports of undiagnosed cranial DI contributing to hypernatremia and followed by osmotic demyelination. So to proceed with the case discussion, I invite my consultants, Dr. Harendra Karunatilaka and Dr. Nandana Digmadagara.
Thank you very much for letting us present this case. Very sorry we couldn't make it more interactive as the protocol suggested. This case highlights how the internal medicine cases are, how difficult they are, and how vague and how. But I think it makes it more interesting to work with these sort of cases. Now, all we know is this patient had hyponatremia of 120, and which was corrected to 170 very rapidly. And then she went on to develop the symptoms with a chronology which suggests osmotic demyelination. Usually, osmotic demyelination has a two-phase illness. Initially, they have seizures and encephalopathy, then they get better, and then they go on to develop various of degrees of quadriparesis with deterioration of the level of consciousness. She had the similar chronology, and she went into develop quadriparesis as she during her hospital stay. And then we have the MRI confirmation of osmotic demyelination. Then we have the clinical picture and the radiology. And then to complicate the matters, because she had very high sodium, we have biochemical confirmation of cranial diabetes insipidus. Now, when you look at the interplay between these two diseases, there are three things that you should know. Number one is, if you're a patient with cranial diabetes insipidus, and at the same time, if the patient has hyponatremia, when you're correcting hyponatremia, they can this cranial diabetes insipidus can have an impact on this rate of correction of sodium, and they can reach very high sodium values very rapidly, and they are at high risk of developing osmotic demyelination. Second thing is, severe hyponatremia itself can cause osmotic demyelination without this picture of correcting hypo to hyper. And the other point is, this osmotic demyelination with severe hyponatremia usually causes extrapontine myelonosis rather than pontine myelonosis. This has been shown in several case reports where the severe hyponatremia due to CDI, cranial diabetes insipidus, has given rise to extrapontine myelonosis rather than pontine myelonosis. Those are the three things that you should know about the interplay between the CDI and the osmotic demyelination. Now, the question is which came first, whether the patient had a partial CDI with intact thirst mechanism. She has been managing well with some insult to the brain. So, whether she had a CDI before the illness. But when you look at her biochemical picture, on the 5th of December, we had a normal osmotic studies. And by that time, she has already set osmotic demyelination. She had exaggerated reflexes, and she had all the symptoms of osmotic demyelination by that time. But at this point, we had a normal osmotic study. So we have intact hypothalamus at this level, we can assume. But about 10 days into the illness, we did the osmotic studies. At that time, we confirmed the CDI. So we can fairly, we can assume that she has developed osmotic demyelination, and then which involved the hypothalamus, which gave rise to cranial diabetes insipidus as a secondary to osmotic demyelination. But still the possibility of a mild or the partial CDI, which she has been harboring without having clinical evidence, unmasked by the acute event, we can't really say no. Here, I'll let Nandana continue the rest of it.
Thank you. Thanks, President and the Council for giving us this opportunity. So as Harinder explained, this is not a common condition. Actually, we have not come across any guidelines or advice regarding these cases. So actually now, as a postgraduate, you should know now the nomenclature has been changed. When you say diabetes insipidus, it has something related to the diabetes. So there were instances in some patients with diabetes insipidus, the nurses were doing blood sugars several times in the ward because diabetes word was there. So there was this arguments, and most of the endocrine colleges now suggest this diabetes insipidus should be named as arginine vasopressin deficiency. And the nephrogenic one, they say arginine vasopressin resistant. So remember that. So that will be the new nomenclature. When you get this, what we call diabetes insipidus, so arginine vasopressin deficiency, clinical presentation, maybe there are a few general characteristics, rarely, clinically may be silent. So, or intact thirst prevents their dehydration. So the things will be more complicated. So there is a group who will have partial cranial diabetes insipidus. They are asymptomatic and maybe subtle symptoms. And they will have mild polyuria, but in full form diabetes insipidus, we see polyuric patients. They are passing about 3-4 liters of urine a day. Then there will be these diagnostic challenges because of the delayed recognition and unmasking the stressors. Most of the trauma, secondary to them, you get, especially the neurosurgical teams know, most of them, they will develop this after the neurosurgical trauma. So when you think of pontine myelinolysis, and there's this extrapontine myelinolysis, out of the this osmotic demyelinating syndrome, only 10% will be extrapontine. So, or they can coexist, the pontine myelinolysis plus extrapontine myelinolysis. So there can be the damage in the extrapontine myelinolysis, basal ganglia, thalami, midbrain, hippocampi, lateral geniculate bodies, all these parts of the brain. Now, when we remember the cranial nerve nuclei, for the easiness, we say first 4 cranial nerves in the midbrain, second 4 cranial nerves in the pons, and last 4 in the medulla. So when you think of the pons, then there will be this 5, 6, 7, 8 cranial nerve nuclei. So you can get the lesion over there. So clinical features will be there when you get the pontine myelinolysis. So overall prognosis in ODS, osmotic demyelinating syndrome, actually it is not a very good condition to have. Most of the patients die of this. Mortality is about 24.8. So, and the recovery, favorable recovery occur in 51.9 patients according to the data. And even if they recover, they will recover with severe residual disability. We have seen some young patients who have been given sodium correction rapidly and getting this thing, and they get bedbound. So maybe whole their families are affected. The earlier recommendation was to give correct sodium may be 6 milliequivalents per day, but you have to remember, even with that you can get. Even normonatremia and hypernatremia also can cause osmotic demyelinating syndrome. So these other electrolytes, so you have to remember other electrolyte imbalances. As I said, not only hyponatremia, hypernatremia, and even hypokalemia, you can get osmotic demyelinating syndrome. If patients clinically develop this, the features of pontine myelinolysis, as I said, 5, 6, 7, 8 cranial nerve palsies, and the rigidity and paralysis of the limbs, you have to suspect it. Most of the time in ICU patients, if you get severe hypokalemia, you can develop ODS. Other thing to remember, the gold standard test to confirm ODS is MRI. If you suspect any patient with pontine myelinolysis or extrapontine myelinolysis, not the CT, you have to do the MRI. But it is not, in our patient actually we got it positive, sensitive for myelinolysis, but it might not happen in the acute stage. Sometimes the changes might be present after about 1 week. So the recommendation is go for MRI even after about 2 weeks if you suspect it. In initial MRIs, you might not detect the this hyperintensities in T2 flare images. So that is the take-home message. If you are suspecting it, delayed MRI is also indicated. Then the management. So what are we going to do for these patients? We have to monitor the serum sodium in central diabetes insipidus or arginine vasopressin deficiency. So we have to do it frequently. It's very difficult in our setup. Actually, getting serum electrolyte once a day is also difficult. So, but at least twice a day, and see you are increasing sodium, the giving 3% saline or reducing the fluid and increasing the salt intake should not go beyond at least the 6 milliequivalent per day. That is the recommended correction. Other thing is now we diagnose this cranial diabetes insipidus patient, and you have to give the desmopressin. We did the test and confirm it, but when you give the desmopressin, it has to be balanced with the polyuria. This patient was not given regular desmopressin, actually advised by the endocrine team also, because patient did not have polyuria. So we worried that if we give, there will be more hypernatremia. So there can be rapid osmotic shift, so it can worsen the condition. So we have to require cautious fluid balance. Yes. So that is the last slide. So as we said, now we did not have any guideline or any case series or something. Only we have the Dr. Bimsara's study regarding plex and the Prof. Indra Kumar's study regarding the steroid. She had a good response for the plex, but unfortunately patient died of hospital-acquired sepsis. Thank you.
Thank you so much, dear sirs and madam, for those impressive presentations. Let's move on to the next session. Before moving on, I would like to ask if there is any question from the audience to the panel.
interesting case. One question, like when you are interpreting the urine sodium in the presence of an AKI, would there be a problem, diagnosing a DI in that situation, if especially if the patient is not polyuric or oliguric? That's
I think CDA was diagnosed because he had a 100% increment in his osmolality with the because he didn't have this polyuria. So 100% increment of osmolality with desmoxicin. So
it's like a retrospective diagnosis. I think it's like, when you have the sodium of 172, there is some recommendation, like if you suspect osmotic demyelination syndrome, get it back to what's your expected sodium.
Yes.
Like, if it is like within 24 to 48 hours, that's the most crucial period.
Yeah, if you're now your expected rise, if your sodium is 120, if you're planning to bring it up to 126, and if they've already gone up to 170, you should bring it back to 126.
Yeah.
That's what the book says. I think it's very difficult to do it in practical sense. Now, the thing is, basically, we were just tinkering with sodium, fluid, antibiotics, and she had a lot of bed sores and pneumonias. But when we go through her records retrospectively, and we are looking at, we knew that she has clinical features suggestive of ODS, and the imaging confirming ODS, and then the biochemical evidence of her CDI. We were just trying to match everything together. If you go into the literature, there's not a single case we could find where the osmotic demyelination of hypothalamus giving rise to a secondary CDI. But there was one partial CDI caused by hypothalamic demyelination in a postpartum woman. She recovered spontaneously. So we don't know what we dealt with, but we thought it's interesting enough to present and have a basically to provoke thoughts, I suppose.
Yeah, the best thing is to prevent.
Yes, that's right. Yeah.
Thank you so much, dear sirs. Let's move on to the next session. For the next case discussion, I would like to invite Dr. P. Supanchana. Dr. P. Supanchana is a registrar in general medicine currently attached to the Colombo South Teaching Hospital. She completed her MBBS degree at the Faculty of Medicine, University of Jaffna, with second class upper division in 2021 and currently following MD Medicine in the Postgraduate Institute of Medicine, University of Colombo. The topic she has chosen for today is when cholestasis meets an impossible pattern, solving a diagnostic dilemma. This case discussion will be led by Professor J. Indra Kumar. Professor Indra Kumar is an honorary consultant specialist physician currently attached to the Colombo South Teaching Hospital, Kalubowila, Sri Lanka. He completed his MBBS degree at North Colombo Medical College in 1991 and received his MD in medicine from the Postgraduate Institute of Medicine, University of Colombo in 1997. And also, he is a senior professor and chair of medicine, Department of Medicine, Faculty of Medical Sciences, University of Sri Jawadanapura. Dear sir and madam, the stage is yours.
Good afternoon, everyone, and thank you for the kind introduction, and thank you for this opportunity. So here our heading is when cholestasis meets an impossible resistant pattern and solving a diagnostic dilemma. So our case is about a 43-year-old male patient from Bandaragama. He presented with fever for 10 days duration with dark urine and yellowish discoloration of eyes for 8 days duration. So on further history, the fever was intermittent, low grade and chills, and 2 days later, he developed dark urine and yellowish eyes. And he had no pale stools or pruritus, or he denied any abdominal pain. And also, he had dysuria and frequency with normal urine output, and there was no hematuria. Also, he complained of loss of appetite throughout this illness without significant loss of weight. So further history, There was no remarkable respiratory or cardiovascular symptoms, no neurological symptoms as well. And he denied any genital ulcers, discharges, joint symptoms, rashes, also denied night sweats. His past medical history was significant for poorly controlled diabetes mellitus for last 5 years duration. He was on metformin and glycoside without a proper follow-up, and he denied any other medications use. There was no significant family history, and social history was significant for which he works as a hotelier in a housekeeping department, and he consumes alcohol and smokes occasionally. He denied any recent travel history and denied any high-risk behaviors. So on examination, he was febrile and he was pallor with mild icterus, and there was no lymphadenopathy and no ankle edema. On systemic examination, his abdomen was soft with normal genitals and non-tender prostate and no prostatomegaly on digital rectal examination. And cardiovascular system, blood pressure was 120/70 with regular tachycardia and did not reveal any murmurs. And his respiratory system and the neurological system was completely normal. So the summary was a middle-aged diabetic male patient presented with fever for 10 days associated with painless jaundice with dark urine, dysuria, and frequency. On examination, he was pale and icteric with tachycardia, and there were no any other examination findings which gave us a clue for a diagnosis. So the main points here was the fever, painless jaundice, and the urinary symptoms. So at this point, we had mainly 3 differential diagnoses of hepatitis, mostly of a viral, and then sepsis-induced cholestasis, and any kind of obstetric jaundice due to a surgical cause with secondary infection. So when we move into the investigation, it shows a neutrophilic leukocytosis with an homocytic anemia and normal platelets, and his inflammatory markers were markedly raised with high CRP of 118 and ESR of 108. So considering his jaundice and the fever, his liver function test shows mildly elevated transaminases with elevated gamma GT, ALP, and markedly elevated bilirubin's level, direct bilirubinemia mainly. And the R factor here came as 0.7, which shows it's a pure cholestatic liver injury. So with these urinary symptoms, we did urine studies. It was normal without any clues, and urine culture was also no growth. So the fever and jaundice and this ultrasound abdomen was completely normal, did not reveal any clues for a surgical cause, and there was no duct dilatation. The other chest X-ray 2D echo were normal as well. And with his anemia, blood pressure showed anemia of chronic disease, and LDH levels were normal. So then came the mysterious blood culture report. It came as Pseudomonas, which was sensitive to imipenem, ceftazidime, and cormoxiclave, and it was resistant to most of the aminoglycosides, especially gentamicin, amikacin, netilmicin, and ciprofloxacin as well. So with this sensitivity pattern, we escalated the antibiotic to meropenem, and surprisingly, with this antibiotic, his CRP was starting to come down, and then it was fluctuating, and fever spikes were persistent. But this cholestasis part was improving. The bilirubin levels were coming down with the duration of antibiotic. So with these persistent fever spikes and these fluctuating CRP levels, we thought whether there would be another pathogen going on. So we moved on to MAR2, which was negative, and CECT chest, abdomen, and pelvis to see any occult infection. It was also normal. So are we missing any diagnosis? Does this sensitivity pattern of this Pseudomonas fit to Sri Lanka? So we thought definitely a sepsis going on with an organism having an intrinsic aminoglycoside resistance. So on further search, we thought of doing melioidosis antibody, which came as positive more than 10,000, and blood culture also confirmed after 1 week it was melioidosis organism. So here, as CECT cap was also normal, and there was no other deep-seated abscesses found. So we managed as melioidosis presenting with sepsis-induced cholestasis, and we managed with 2 weeks of IV meropenem according to the guideline, and then discharged him on oral cotrimoxazole, planned for the eradication therapy. And on follow-up, 3 days later, after discharge, he came back again with fever and the same dysuria, but this time he did not have any jaundice. And this time as well, he denied any other respiratory or any other systemic symptoms, and examination revealed no clues for the cause of the illness. So the repeat urine full report and the repeat urine culture showed normal, and previous CT cap also showed no abscesses, but the CRP has risen to 250. So with these persistent urinary symptoms and the background melioidosis, with normal urine studies, we went ahead with TRUST scan, and it showed 2 prostate abscesses, both on the one on the right and the other on the left, with remarkable sizes. So with microbiology team input and GU team input, we managed with 4 weeks of IV meropenem and followed by 3 months of oral comoxiclave and doxycycline. As this, with the follow-up TRUST scan showed reduction in sizes of abscesses with the antibiotic. So we managed without drainage. Thank you.
Thank you, Subhachana, for highlighting that case. So I'm here to just to point out some interesting and important facts that I think as postgraduates should be taking note of. Now, this is a case where initially presented to us with a fever and a jaundice. So generally fever and jaundice in a young male, diabetic male, and there was a prosthetic symptom. So the first challenge was that to sort out what this fever and jaundice. So what do we do when you get a fever and jaundice? First we classify the jaundice, right? Whether it's conjugated or unconjugated, right? And we determine the pattern by doing R factor score. And we did that, and we took it on the next level because it was a cholestatic R factor. We went to the next stage where we need to find out what is the cause of cholestasis. And to our knowledge, it came as no obstruction, normal bile duct size. Then we need, now the patient is having fever, there is normal bile duct, but there is cholestatic jaundice. It's a bit of a confusion state. Then next rational things to do is to do a blood culture and look for a source of infection, an abscess. And then you find and treat and see whether this liver function improves. Because we are not thinking of any obstruction or cholestasis due to any cholangitis or anything in the state, because there is no obvious obstruction. So it is just a management framework I would just try to share with you when you find a patient coming with a fever and jaundice. So, since there were no obstruction, the next point that we'd like to highlight is that we do come across uncommonly sometimes cholestasis associated due to sepsis. Now, what is the pathophysiology in that case? Why should a fever cause cholestasis in the absence of any mechanical obstruction? Well, there are 4 mechanisms, but of which the most important mechanism is the cytokine storm. Cytokine storm. We also know that due to other oxidative stresses, toxins of the bacteria, due to lipopolysaccharide endotoxins, and some hepatic circulatory hyperperfusion all contribute to this unique condition called sepsis-induced cholestasis. It's a bystander effect. The liver is not the source of infection. Clinical presentation of this condition, usually it's seen in conditions like urosepsis, intra-abdominal infections, abscesses, pneumonias, and severe gram-negative sepsis. The prevalence is said to be, in some studies done in Australia, it goes up to about 20% of hospitalized, mainly ICU patients, especially, following a gram-negative sepsis. The important thing to remember is that it is reversible with effective treatment, and bilirubins get normalized within 2 to 4 weeks, and thereafter the liver doesn't suffer any permanent damage. So how do we clinically recognize this? As I told you before, that the 3 things, that is somebody with an active infection, and jaundice, which is due to cholestasis without an obstruction. Then, if you look at the liver function, it will show the ALPs and the gamma GTs are much more higher than the AST-ALT, as in our case, with a R factor of 0.8 or 0.9, normal bile duct. This is the point I would like to stress the trainees, not to rush into diagnosis of any obstruction or ascending cholangitis, or which are much more recognized. So we need to be cautious in jumping into such diagnosis. We need to also consider the other differential diagnoses other than the obstruction, like subphrenic abscesses, drug-induced. Sometimes drugs can cause liver damage, and acalculous cholecystitis. And sometimes if you don't look at the conjugated and unconjugated component, even hemolysis can be associated with fevers. So we need to clinically recognize using this pattern. So having recognized this as melioidosis, how do we justify that in our patient? Right. Now our patient was a diabetic, which is the known highest risk factor. Especially being a poorly controlled diabetic is the highest risk factor. Right. And being in an endemic area is the second. And exposure risk is the third. Now, I'm not quite, when he said housekeeping, but probably is doing some cleaning work, and in the hotel where he may be exposed to this water contact and infection. So people who are doing housekeeping, hoteliers, agricultural constructions, anybody coming into water contact, mud contact. And it's important for the post-grad to remember that it's a great mimicker. It's a great mimicker, right? I don't know how many we would have missed in the past. So you can have a bacteremia, important thing, without any focus of infection. Now, this is as in our patient was a classic example, where there was no focus of infection on CT, right? So he just came with bacteremia, fever, and jaundice. And the only way we detected was detecting bacteria in the blood. So this can present without any focus of infection. That's point number 1. And also it's a high mortality if you don't treat, and it can progress very rapidly, which happened in our case. Within few days, it went to the prostate, and we were able to detect it. And it has been known that CT sometimes can miss an early abscesses, whether it's prostatic or intra-abdominal. If there's early abscess, can. So we need to be cautious. And it mimics our commonly treated, we always treat patients on some presumption, is TB, fungal pneumonias, fungal infections, right? And multiple liver abscesses, sometimes amoebic liver abscess, we think it's amoebic and we treat. So we don't know how much we are right or wrong. So we need to be very cautious because it is being increasingly detected in this country. So I think we will have more and more cases in the future. The key that really helped us to detect was this kind of pattern. I'm sure all of you must have seen this kind of pattern at some stage, because increasingly people are not used to detecting the melioidosis, so they quickly, Pseudomonas is so common, so it's easy to say that it's a culture Pseudomonas and this is a resistant pattern and this is a sensitive pattern. So the doctors, clinician looking at the resistant pattern will get an obvious clue that this is not the Pseudomonas that we are usually in Sri Lanka, where mostly they are sensitive to all these antibiotics that were said to be resistant. So the pearl is that when you have a Pseudomonas which are resistant to gentamicin or colistin, right, which is not very typical. Think of something else like this. They are very, very, and also they say on the other hand, they are sensitive to amoxicillin-clavulanic acid, but resistant to the usual gentamicin. These two really should ring a bell that this is the culprit. Because in Sri Lanka, most of the time, that Pseudomonas is sensitive to these organs. Right. Then the other point I would like to highlight is the hidden abscesses. So we are here by incidentally detected the hidden abscess because the patient went home, get better, and still had persistent. We trusted the CT, everything, chest, abdomen, pelvis, everything normal. So there was no focus of infection. So this is the hidden abscess or early developing abscess. So important to remember that this can be presenting as a pure septicemia without a focus of infection at the initial stages. Studies have shown that 96 to 100% of negative predictive value, people who have negative for urine infection with cultures and UFR can be excluded. Now, this is not the case in our case. So our case is much more deeper rooted, which is a prostatic abscess without involving the urinary system. Even in that case, 93% of the prostatic abscesses show some sort of clinical evidence, either symptoms or positive. In our patient, it's only showed the symptom. That's an important point to remember. So what is the implication? So you can have a prostatic abscess very well sitting there without any symptoms. Even you have 7% of the patients may not have any symptoms, negative culture, nothing. So don't exclude urinary tract infections of this nature just because the cultures and everything are negative. It's important to do a TRUS. That's where we clinch the diagnosis in the end. So always the clinical suspicion. Now this is an important lesson for postgraduates. A clinical suspicion overrides any form of investigations. Right? You see the CT was negative and it's simple to say, okay, go, finish, no infection. But the patient had persisted urinary symptom, which provoked to do a TRUS. So this is a lesson to learn that clinical suspicion is far more important than the results. So finally, the important thing to also remember is that don't cut short the duration of treatment. About 20% or 25% people relapse. Patients get better soon, within weeks, within months, patients get better. Don't cut short the duration. 3 to 6 months you have to treat because relapses are common and they are more serious. Right? And look for hidden abscesses, especially in a patient with diabetes. And don't forget prostate is a site. About 15 to 20% of the patient with melioidosis can have prostatic abscesses. So don't be fooled by patient getting better, ESR, CRP coming down, patient symptom getting better, because patient is better, patient is cured, but he is going to relapse 25% of the time, even if you leave a micro abscess, residual small infection focus. So the bottom line is it requires prolonged therapy, high index of suspicion for occult abscesses. This is my final slide. So the treatment, I don't want to go through these slides about the treatment. Thank you.
It's time for the audience to come up with questions if there's any.
Melioidosis was classified as a pseudomonas. Later they changed. So there may be some common characteristics of the...
Yeah, the morphological characteristics,
so
because both are gram-negative organisms and similar morphological characteristics.
So if the pseudomonas is sensitive to those drugs, then they should have checked for the other things. Yes.
With the absence of any more questions, we'll proceed with the next session. Thank you so much, sir. We will now proceed to our next case discussion. This case will be presented by Dr. Hiruni Amanda. Dr. Hiruni Amanda is a senior registrar in internal medicine, currently attached to the National Hospital of Sri Lanka. She completed her MBBS degree at the Faculty of Medicine, University of Colombo in 2019, completed MRCP UK in 2023, and received her MD in Medicine from the Postgraduate Institute of Medicine, University of Colombo in 2025. This case discussion will be led by Dr. Harsha Satish Chandra. Dr. Harsha Satish Chandra is a consultant physician specialist in internal medicine, currently attached to the National Hospital of Sri Lanka. He completed his MBBS degree at North Colombo Medical College in 1991 and received his MD in medicine from the Postgraduate Institute of Medicine, University of Colombo in 1997. He is a trainer and examiner in general medicine, Postgraduate Institute of Medicine, University of Colombo. Dear sir and dear madam, the stage is yours.
So we will be presenting a case which we thought was a diagnostic challenge, so similar to, I think, what Prof. Indra Kumar presented. So I invite my senior registrar, Dr. Hiruni, to present the case.
So our topic for today would be thinking beyond the organs, connecting the dots in multisystem disease. So this is based on one of our patients, a 68-year-old female with a background history of ischemic heart disease, hypertension. She presented to us with 1 month history of fever. This was an intermittent fever, which was more pronounced towards the evening and was associated with loss of appetite. In addition to that, this was accompanied by bilateral lower limb swelling of 2 weeks duration with generalized body itching. However, there was no yellowish discoloration of eyes, hematemesis, melena, or abdominal distension or pain, or any frothy urine, facial edema, hematuria, or shortness of breath, paroxysmal nocturnal dyspnea, or thopnia to suggest a heart failure association. And she did not have any travel history or significant risk factors for liver disease. Her urine output was good and clinically euthyroid. And upon further questioning, she complained a history of dry eyes and dry mouth for 1 year's duration, and she has been self-managing with eye drops for the past 1 year. And it was also associated with some degree of alopecia that was also for 1 year. However, she did not have any photosensitivity rashes, oral ulcers or genital ulcers, any arthralgia, myalgia, or Raynaud's phenomenon. And past medical history, she had well-controlled hypertension and ischemic heart disease, and she had a history of renal pathology about which patient was not fully aware of. Apart from that, she was on bicarbonate and dual antiplatelet and antihypertensives. There was no family history of chronic liver disease, renal impairment, or malignancies. So with this prolonged fever and ankle swelling, pruritus patient, our physical examination revealed a BMI of 20, bilateral pitting ankle edema. There was no facial puffiness with minimal alopecia. And she did not have any peripheral stigmata of chronic liver disease, any photosensitive rashes or features of CTD, and there was no clubbing, lymphadenopathy, there were no red eyes, no tender swollen joints. Her abdominal examination revealed no organomegaly. There were no free fluid. Cardiovascular system examination was normal without any elevation of JVP. BP was normal with normal pulse pressure and no murmurs. However, her respiratory examination revealed bilateral basal crepitations that did not alter with coughing with normal saturation, and neurological examination was normal. So, upon further inquiry, we got down her past medical records that revealed a diagnosis of renal tubular acidosis in 2003 following a presentation with a febrile illness, for which she was on long-term sodium bicarbonate. Apart from that, further evaluation or regular follow-up has not been done. So in summary, this is a 68-year-old female with a history of ischemic heart disease, hypertension, and a long-standing diagnosis of a renal tubular acidosis, presenting with a febrile illness of 1 month duration, which was associated with lower limb swelling, pruritus, loss of appetite, with a background chronic history of dry eyes and minimal alopecia for 1 year. Examination revealed mild alopecia and pitting ankle edema and bilateral fine crepitations.
Thanks, Emily. So this is supposed to be an interactive session, I think. So I would like to ask our postgraduates, at this point in time, what would you consider as likely differentials in this case? I think if we sum up the case, so it is a 68-year-old female with a background of some comorbidities, ischemic heart disease, hypertension, but a thing of note would be, an unusual thing would be renal tubular acidosis, of which we didn't have the complete records. And then the patient had presented with fever for 1 month and swelling of legs with some pruritus. And of course, dry eyes for a period of 1 year. And the examination was not much, but she had pitting ankle edema bilaterally and fine basal crepes. So what differences would come to your mind? So, okay, I would try to answer, I think, since we'll probably get you involved a bit later. So the initial considerations were whether this was due to some chronic liver cell disease on the basis of some of the symptoms she had, pruritus and some constitutional symptoms as well, and then presenting with fever and bilateral ankle edema. So, and of course, there was a background to hint at some autoimmune pathology with dry eyes and alopecia as well. So that's the background of this patient. So out of the chronic liver cell diseases that we would consider in this case, I think if we think of an etiology, probably an autoimmune hepatitis or a primary biliary cirrhosis, biliary cholangitis would come to our mind. In view of her age as well, she is, well, of course, a little past 60, but generally in the 40 to 60 age group, you would encounter these diseases more commonly. So whether there was an autoimmune hepatitis or a primary biliary cholangitis was one concern. There was this pruritus to suggest a cholestatic pattern. And of course, we cannot ignore, because she had fever as well, we cannot ignore the possibility of viral hepatitis. And I suppose, other diagnoses like Wilson's disease will also have to be excluded. But those were the main things that we considered as possible chronic liver cell etiologies which might lead to this clinical picture. Then, of course, an autoimmune disease was suggested by the symptoms that I mentioned earlier. And in a 68-year-old female, I think malignancy cannot be ruled out at this stage, presenting with leg swelling, pruritus, some constitutional symptoms of some abdominal pathology might be there. So that's something that we have to consider. So those were the initial considerations. Anything else you think would be relevant in this case that we missed? Okay. Hiruri, can you present this?
So, bearing those differentials in mind, we went ahead with the basic investigations, which showed a macrocytic anemia and a thrombocytopenia with elevated ESR, normal CRP, and her basic infection screening were negative. And the TB studies were negative. Blood picture revealed macrocytosis with microcytic hypochromic and cells and acanthocytes with thrombocytopenia. And renal functions were in high normal range with a hypokalemia, hyponatremia, and UFR showed albumin +1 without any infection, and the protein quantification was in subnephrotic range. Her liver enzyme showed elevated AST, ALP, gamma GT, which was a mixed cholestatic and hepatocellular pattern of mixed liver injury with the hypoalbuminemia, the thyroid profile and the echo were normal. And her blood gas showed a normal anion gap metabolic acidosis with elevated urinary pH of 6.4, and her abdominal X-ray showed nephrocalcinosis. And her chest X-ray showed mainly bilateral basal predominant opacities with reticular shadowing. We went ahead with the HRCT since she had fine crepitations as well, which revealed bronchiolitis obliterans. With this, her RTA was typed as a type 1 distal RTA with urinary pH being higher than 5.5, and the etiology was not previously looked at, and it has been long standing. She has been receiving bicarb for that.
So at this point, I think this is time for your input. What would you think about the differentials? Do we have to revise the differentials that we discussed earlier? If I go back to, I think there's quite a bit of information, so I'll go back to the previous slides. So there was a macrocytic anemia, which is quite clear, with thrombocytopenia, and a high ESR with a normal CRP. The cultures were negative, infective screens for TB was negative, and the blood picture also showed macrocytes, and there were some hypersegmented neutrophils, and thrombocytopenia was there, but LDH was not high. And then obviously there was a hypokalemia, which was quite evident, and as expected, there was a liver pathology, and there was, as Hiruni said, there's a mixed picture of transaminase increase with a cholestatic pattern as well. ALP was high and gamma GT was also high. But the bilirubin was normal, and there was hypoalbuminemia, and this was something that we didn't really expect. There was albumin in the urine, and there was a subnephrotic range proteinuria, which was something that we did not detect or suspect on the basis of her symptoms. So that was unusual. And of course, the blood gas showed that there was a normal anion gap metabolic acidosis, which is in keeping with the earlier diagnosis of RTA. So we could probably confirm that further by the urinary pH, which was 6.4, and she was having trouble acidifying the urine. And a pH of over 5.5 is, in this setting, is diagnostic of renal tubular acidosis. So that, I think, was confirmed on the basis of that. The X-rays showed evidence of, I think, I don't know if you can appreciate, there is a bit of haziness in the lung bases in the chest X-ray, so there may be some lung involvement there on the basis of that, and the HRCT showed that there was evidence of bronchiolitis obliterans that's caused by inflammation in the small airways, and there was calcium in the kidneys as well. So those were the findings. So what would you give as differences? Yes. Sjogren's, yeah. Yeah, I think on the basis of, she had dry eyes, I think, going on for 1 year, rather developed 1 year back. So, and Sjogren's could explain some of these other multi-system involvements, but of course, so far we don't have anything to prove it, but we could have a suspicion because there was renal tubular acidosis and then a multi-system involvement involving, although it's not very common to get lung involved, well, I wouldn't say it's not common, but it's possible to get lung and renal involvement. So that is one possibility. Then, of course, back to our earlier diagnosis of liver disease, now we could, I think, now strongly suspect either autoimmune hepatitis or primary biliary cholangitis. We cannot exclude primary biliary cholangitis because there was a cholestatic pattern, and so far we don't have any evidence to say that one is more likely than the other based on clinical signs alone. And of course, still we have to exclude viral hepatitis and Wilson's disease because we have to find treatable causes and treat them. That's the basis of, I think that's a very important basic principle in medicine. So I think we would have to proceed with some specialized investigations, including an ultrasound, and Hiruni will elaborate on that.
So our further investigations in ultrasound abdomen revealed cause liver parenchymal echogenicity suggestive of chronic liver disease and the medullary nephrocalcinosis that was revealed previously in the X-ray. And with regard to her liver involvement, bearing our differentials in mind, we did the viral hepatitis screen that was negative. KF rings, cellular plasmin were normal. And her ANA was significantly positive, 1 in 640 with a nuclear pattern. And anti-smooth muscle antibodies were positive with elevated IgG levels. However, her anti-mitochondrial antibodies were negative, and MRCP also we went ahead, that revealed no obstruction. So with this in mind, since we were considering more towards autoimmune hepatitis regarding her liver involvement, we went ahead with a liver biopsy. So the liver biopsy showed evidence of interface hepatitis. This was classical of autoimmune hepatitis without any evidence of significant duct involvement to suggest PBC. And also there was in the biopsy evidence of established liver disease with some degree of fibrosis. So the conclusion was chronic hepatitis with chronic autoimmune hepatitis. And so to fulfill the diagnosis, we applied the simplified autoimmune hepatitis diagnostic criteria. In our patient, she had significantly positive ANA titers with positive anti-smooth muscle antibodies. And we did not go ahead with liver, kidney, or soluble liver antigen tests. But however, she fulfills the scoring for the antibodies, and also with immunoglobulin, also she had a significant level of elevation. So more than 1.1 times the upper limit gives the maximum marks, and histology was suggestive, and she did not have any evidence of viral hepatitis. So with this, from the diagnostic criteria, she fulfills the criteria for a definite autoimmune hepatitis. But since some clinical features were there for possible PBC, we applied this Paris criteria to see whether there is an overlap of AIH PBC. However, there was no suggestivity of an overlap. Even though she had elevated ALP, her anti-mitochondrial antibodies were negative, and there was no biopsy evidence. So in autoimmune liver diseases, there can be instances of overlap. However, in this instance, we excluded, and our AIH diagnosis was confirmed. So there can be some degree of 5 to 10% of AIH can have a cholestatic pattern. So in addition to that, since AIH patients can have other extrahepatic autoimmune diseases, and also since our patient had some clinical features suggestive of autoimmunity, we went ahead with immunological workup. Since initially there was a consideration of SLE and significant ANA titer, we did dsDNA, that was negative, and anti-Smith antibodies were negative. And her complements were normal, rheumatoid factor was negative, and the ENA panel revealed anti-Rho and La positivity, suggestive of Sjogren's syndrome, as the clinical features were also compatible. So this patient, in addition to the autoimmune hepatitis, has Sjogren's syndrome and renal tubular acidosis. Sjogren's syndrome can have other organ-specific autoimmune disease association and can have multisystemic involvement. And also if it is associated with any other systemic autoimmune disease like SLE, rheumatoid arthritis, that is called secondary, but our patient had primary Sjogren's syndrome. With regarding extraglandular involvement in Sjogren's syndrome, this is thought to be due to lymphocytic infiltration of the epithelia, and they can have generalized constitutional symptoms, cutaneous involvement, and multiple respiratory involvement like bronchitis, recurrent sinusitis, and bronchiolitis obliterans have also been described. Commonly, they can have a ILD, which is typical of lymphocytic interstitial pneumonia pattern. And there can be GI involvement, neurological involvement, and renal involvement also can be, in addition to the renal tubular acidosis that is commonly known, they can have a chronic interstitial nephritis, even MPGN pattern of glomerulonephritis can be there, which would explain our patient's proteinuria. So with regard to the management of this patient, since she had this current diagnosis of autoimmune hepatitis, primary Sjogren's syndrome and distal renal tubular acidosis, initial management with immunotherapy, we started her on prednisolone and combined with azathioprine for induction and maintained with azathioprine. And also since she had some features of chronic liver disease, we started her on non-selective beta blocker, and upper GI did not have any significant evidence except for early varices. With regard to Sjogren's, she was managed with symptomatic management with eye drops, and the distal RTA was managed with sodium bicarbonate.
Yeah. So at this point, I think we could probably come to a comfortable, reliable diagnosis of autoimmune hepatitis with Sjogren's and other associations. Now, her liver disease, though, as Hypni said, there was evidence of early varices, so she had developed chronic liver disease. And the diagnosis of autoimmune hepatitis was also very clear. She had the symptoms and the signs, and then, of course, ANA was positive, and anti-smooth muscle antibody was positive, and AMA was negative. And the liver biopsy was very suggestive of autoimmune hepatitis on the basis of interface hepatitis, which was very clear. And there was no infiltration of the bile ducts to suggest any cholangitis component. So AIH was firmly diagnosed. And then, of course, we have to consider whether we have not diagnosed her AIH early enough, because she has now progressed to chronic liver cell disease. So along the line, probably we have not been able to diagnose her early enough. She may have had certain symptoms. But of course, now we have started on the steroids and the appropriate treatment to slow down the progression. And one word about autoimmune hepatitis, the other important thing is that we must exclude the viral hepatitis, especially hepatitis C, because that's curable nowadays, so that has to be excluded. And of course, Wilson's, and of course, on the basis of the other investigations, we can come to a diagnosis of AIH and then treat appropriately. Then some of these patients with autoimmune hepatitis have a strong association with Sjogren's disease, and that is something that we have to keep in mind. And Sjogren's disease is, as Hypni pointed out, is a multi-system disease with many involvements. It can have the classical dry eyes, which our patient had. Then we were a little puzzled by the proteinuria, that subnephrotic range proteinuria that this patient had, but that can be explained on the basis of renal involvement. The common renal involvement in Sjogren's is a tubulo-interstitial nephritis, because there's a lymphocytic infiltration in the body in different organs, so there can be a tubular interstitial nephritis. So that can commonly lead to proteinuria. There can be glomerular involvement also in some cases, although not very common. So multiple pathologies are there to produce proteinuria, and we were initially a little puzzled why she had developed proteinuria in this case. And then, of course, the pulmonary involvement, the classical Sjogren associate is an interstitial lung disease. About 20% of patients can develop interstitial lung disease, but equally important is a bronchiolitis, where there's inflammation of the small airways. And in the literature, it's described that up to about 10 to 20% of patients can actually have a bronchiolitis. So this patient did have it on the basis of the HRCT, and it was suggested to us by the unexpected finding of crepitations in the lung bases. So to sum up, I think this case probably highlights the importance of considering autoimmune overlap syndromes, which are not that uncommon. So we should not rest on our laurels with one diagnosis, but try to think of the other possibilities, the other associations, because they may be important in the management of the total patient. Thank you very much. Yeah, if there are any questions, we'll be happy to answer.
Very, very interesting case you had just presented. I was wondering, now this patient had 1 year ago dry eyes. So was not ophthalmologist or eye surgeon would have thought about to investigate for Sjogren's at that stage?
Yeah,
she had not shown it to any...
I think she had not come for follow-up.
Actually, sir, she is self-medicated with eye drops for the dry eyes. That has not been evaluated.
And the other thing is that since now it's evident that she had developed Sjogren's first, so with the eyes and all. So is the hepatitis is part of the Sjogren's, or you think that it is the AI, autoimmune hepatitis and Sjogren's are two different conditions associated here? But to me it feels like that since the hepatitis came later, so it is an renal involvement, lung involvement, liver involvement, all I thought part of Sjogren's rather than a distinct autoimmune hepatitis.
Yeah, I think probably you're right, because she may not have had hepatitis for long. Otherwise, she would have developed very overt, decompensated chronic liver cell disease. She didn't just had ankle edema. That may have been just due to low albumin, which was contributed to by the proteinuria as well. So, and she did not have any ascites. So probably the hepatitis was a late development, and she may have had the Sjogren's going on for quite some time. And this became manifest later.
Thank you very much for that excellent presentation and a nice case discussion. One suggestion is like, is there another dot of Ivan syndrome evolving in this patient? Because like she was having thrombocytopenia and anemia. Yeah, and we know that this is all interconnected connective tissue disorders.
Yeah.
Even though blood pressure didn't suggest of any acute hemolytic anemia, but of course.
Yeah, of course. I think we'll have to keep monitoring her for that as well. So I think you gave the right message. So it's a continuous process of monitoring. We cannot just sort of stop reviewing her. And the other thing is autoimmune hepatitis can relapse very easily. So almost 50% of patients relapse. So unless we keep monitoring her carefully, we are going to have issues and with her non-compliance as well.
Regarding the liver biopsy,
yes.
So knowing that patient has chronic liver cell disease, previous ultrasound also showed chronic liver cell disease, and the liver biopsy is an invasive procedure. So can't we manage this patient without a liver biopsy, because this is considering the background, it is more likely autoimmune. So and can't we manage without?
Yeah, the issue is here. I think if we have the autoantibody profiles early enough, we probably can do that. But I think we got some of the reports a bit later. So at that point, primary biliary cholangitis was an important differential which we could not exclude on the basis of, because she had a cholestatic pattern as well, which was a bit unusual for a pure autoimmune hepatitis. So that's why we went ahead with the liver biopsy. But I mean, if we had evidence of all the antibodies, AMA being negative and anti-supermass antibody being positive and ANA being positive, then of course we could have diagnosed it on that basis also. So we had to perform the liver biopsy here.
Thank you very much, sir and madam, for that very interesting and interactive session. So we hope you all found the discussions useful and fruitful. So we are truly grateful to all our speakers for their excellent academic sessions and the valuable time and knowledge they shared with us. So as a token of appreciation, we will now present mementos to our speakers today. So first I would like to invite Dr. Harendra Karunatilaka. And before that, to present the tokens of appreciation, I would like to invite Professor Namal Vijayasinghe and Dr. Madhuwanti Hettiarachchi. His valuable time and knowledge with us. Dr. Nandana Dikmadugoda. Dr. K. Nilusha Madurangi. Professor J. Indra Kumar. Dr. P. Supanchana. Dr. Harsha Satish Chandra. Last but not the least, Dr. G. Hiruni Amanda. Before we conclude, we would like to express our gratitude towards everyone who made this day a success. So I would like to invite Dr. Dinuka Liyanage, the Honorary Joint Secretary of Ceylon College of Physicians 2026, to deliver the vote of thanks.
Good afternoon, everyone. Actually, I'd like to take this opportunity to thank all the speakers and faculty and the SRs and registrars who have made this event very successful one. And special thanks goes to Dr. Madhuvanthi Hettiarachchi and Dr. Suranga Manilgama and all the speakers. I would like to thank on behalf of the President and the Council. Thank you very much. Hope to see you in another fruitful sessions. Actually, we have 7 more specialty updates in time to come. Stay focused to CCP and take them at maximum advantage from CCP college sessions. Thank you.
Thank you. That brings us to the end of today's program. Thank you all speakers, panelists, and participants for engaging an insightful session. Have a pleasant rest of the day. Thank you.